So good afternoon, everybody, and thank you all for coming along. My name is Nasa de Burka. I'm the Regional Practice Education Coordinator. And today our regional webinar is on the regional digital landscape, present and future. So like I said, thanks everyone for coming along. We are going to share the slides and the recording afterwards. And also we will have a little feedback link in the chat. So we really appreciate if people could give us their feedback, because we use that then to decide how we manage further webinars. So it's very useful to us. Also, if you could pop your questions into the chat, we will either reply to them as we're going along, or else we will address them hopefully at the end in the question and answer section. And just finally then, just to make sure everybody should be on mute, but just if you hear yourself, will you put yourself back on mute? So we're very happy today to have Vincent Jordan here to open the webinar for us. Vincent is the Regional Director of Technology and Transformation for the region, and I'm going to let him speak to us now. Thanks, Vincent.
Thanks very much, Nessa. Is somebody going to put up the slides? Okay, perfect. Yeah. Thanks very much, Dawn. Okay, so first, I'd like to just thank you all for taking time out of your day. We know that you all have a lot going on with your patients and the people that you're giving service to. So thanks for taking a bit of time out here. This is something that we kind of spend most of our time on, and it's great that you've got a level of interest to hear what we're looking to do and how we're looking to support you and your colleagues with the digital capabilities that we've got in the region and how we're expanding those over time. I'm just, well, firstly, Nessa's introduced me. I'm the Regional Director for Technology and Transformation here in the West and Northwest. I work across the region, our team work across the region, and we work very closely with the centre. I'm going to give a brief overview of the direction of travel that we're taking as a region. And then we're going to get into a little bit of detail about the specifics of where we are right now, in particular with some of the things that we've been doing to bring our platforms to many more settings that patients present in. And Dawn is going to lead on that and is going to touch on some of the upcoming developments and some of the work that we're doing to try and bring additional capabilities in. And then at the Q&A at the end, we'll have Paddy and Anne and Dawn and myself just kind of fielding the specific questions that you might have there. Okay, so we'll just move on. Actually, I think that the next slide just kind of touches on those. So so this is really roughly the run plan for it. We'll move just to the next slide, please, Dawn. There's a lot of text on this, so I apologise for that up front, but it'll be helpful for you perhaps after the webinar to be able to refer to this. Some of the things that we're working on right now are to get the foundations right for that much improved digital future that we're looking at. We have a lot of digital capabilities. They're not all very well joined up, and so some of what we're doing right now is to try and get to a place where we're making the best use of the products and the digital capabilities that we have. That includes making sure we've got the best value we can from the existing digital estate. Very often, as we work with the clinical teams, they see something that will really help them solve a very particular problem that they've got. That can be quite difficult to deploy in a sustainable way because we're really heading in this direction of integrated care. So what we're trying to do is say, if we've got something that's good enough right now and we can provide that in a connected way, it just gives us a much better way of supporting the patient journeys that come at us from all sorts of different directions. So getting more value out of the existing estate, using some of the key platforms in more settings, fixing where we've got gaps in our infrastructure. And this is really a significant challenge across the whole of our environment, particularly with the increasing and changing cybersecurity threats. So we spend a lot of time working on trying to keep stuff safe. We've had a couple of things popped up this week where trying to understand what those technical matters are. It's actually around some of the technical integration work, and actually trying to resolve that and make sure that we don't introduce additional risk to the data that we hold on our patients and the services that depend on that. So we spend a lot of time in this space trying to keep stuff safe, and we'll continue to do a lot of that. Building the digital team, so we can engage and we can make sure the solutions become fit for the services. And we have to deliver at scale, and that's a big challenge for us across the organisation. Just delivering at scale. Often we need to have delivery through teams, but you'd be familiar with this with your own work and the move to a lot of multidisciplinary work. We need to do that on the digital side as well, and partnering with people that are in frontline roles like yourselves. And then the other key thing that we're at is to make sure that the national strategy, Digital for Care 2030, that is a joint position between the Department of Health and the HSE, that what we do is aligned with that programme, and that programme ensures it's aligned with what the needs are in this region as well as in other regions. So working with the national teams around that. Some of the stuff on the right we're going to talk about in this webinar, so I won't touch on this other than briefly. Essentially, we need to move to platforms, so away from single point solutions and things where we can see the patient journey. You'll see a couple of examples of that today. And we're going to be doing more and more of that. We'll move away from point solutions. We'll move to doing the best we can with our platforms. And the really big prize that we're trying to make sure we position ourselves well for is the National Electronic Health Record. So what we do now to consolidate our services onto a smaller number of platforms is a key part of readiness for that national EHR. And then there's other matters here that you can see, making sure we continue to protect our systems and our services. We improve the foundations, such as connectivity. We get better at data analytics. That's a big opportunity area for us. And you can see a couple of other things in that. So that's really just a brief direction of travel. We're going to move more and more towards platforms. We've already been doing that for the last several years. We will look at when we introduce some new capabilities, that we do this across the space that we're working on, that we don't just do it in kind of small pockets of service, but we try and bring a capability across all of our services. So that's the direction we're moving in. And I'll now hand over to Dawn, who's going to explain some of the work that's been going on to bring our capabilities into those additional integrated care service settings. So Dawn, you might wish to introduce yourself then.
Thank you, Vincent. Hi, everybody. My name is Dawn Fletcher. I am the ICT application lead for the Galway, Mayo, Roscommon area, which is previously known as CHO2. I work as part of an ICT team, which we help to deliver and maintain and integrated various ICT systems across our area, which are also used by our colleagues within the acute sites for the West Northwest region. And again, it's that whole integrated approach that we're trying to streamline when delivering patient care. So as I move through the slides and I outline the various ICT systems that we have in place, you will see the importance of the joint up information and so on that we have. Now, I do refer as patients. Now I know we also have clients, servers, users, and residents, so bear with me on this one. So our very first slide here is our core platform ICT systems that we have in place. So we start first with IPIMS, which is our Integrated Patient Management System. Now with IPIMS for our region, for the West Northwest area, it's a multi-campus site IPIMS, which means that it's one version or one instance of IPIMS that we all use, which in turn leads to a singular PID for the patient, which I'll step through a bit more on my next slide. So we use IPIMS as a referral management system, our waitlist management, our appointments, cancellations, and DNAs when it comes to our clinic appointments and so on. We also have SMS text reminders, which we send out using the patient's contact number with a 10 and 3-day text reminder. We can pull active metrics from IPIMS as well in the form of SRS reports and crystal reports and so on. We have diagnostics, which is our Apex iLabs, our SunQuest system, NIMS, AGFA, PACS, and RIS. We have Evolve, which is our electronic document management solution system, a repository of information for the management of patient care. We have TPRO, which is our mobile dictation system. And again, that takes the feed from IPMS, which I'll show you in a few moments. And with that, then we have aligned all of our services with the HSE app. And again, the HSE app takes a snapshot of the patient information from IPMS with regards to referrals, waitlist, appointments, TCI dates, which are your 2 come-in dates for your acute sites and so on. So again, it's joining up the patient information for the patients to see, which they can download the HSE app and use their GovID number to be able to log into the app and view these details. We also have specialised information systems such as Diamond for the CHO2 area and Pro Wellness for CHO1, which is used for the management of diabetic patients. We're also engaging with the ICNet team, which is the infection control teams and so on, to enable that for our CNU units. Now, we also have mental health, district hospitals and the community nursing units set up on the same multi-campus version of IPMS. We have telehealth appointments, and again, I know these are not new to the service, but we have telephone consultation clinics and Attend Anywhere video clinics. So with the Attend Anywhere service, we also have a unique appointment letter with the hub or site URL link embedded within the appointment letter and the QR code. We also have the URL link embedded within our text reminders, which again are sent out to the patients and service users to remind them of their upcoming appointments. So that's our core platforms. So my next slide then is just a summary of IPMS within the West Northwest region. So as I said, IPMS is a central patient management system which is used by both acute and community services across the West Northwest. So what that means is that we have a unique patient identifier across the HSE West Northwest region, which will capture the patient's demographics, next of kin, and we have that single platform for capturing our patient records, admission notes, discharges, transfers, referrals, waitlist and EDs. So with that one PID number, you will see the patient activity across all of the acute sites for the West Northwest and for the community sites that we've set up in IPMS. So in a while, I'll actually show you a screenshot of what that looks like and how it can be used within your service. As I said, we have also introduced our SMS text reminders, which has led to, in the first few months, a 46% reduction in our DNA rates within our chronic disease hubs. And again, this system, which is called Clarity, pulls the appointment details, time, date, location into the text reminders for the patients. As I said, it's a 10 and 3 day usually, and helps reduce down our DNA rates. So access to IPMS itself is managed through individual users' accounts, which are aligned with the HSE policy to ensure data security and compliance is kept at the forefront at all times. We have KPI functionality available, and as Vincent has mentioned earlier, we're joining up our reporting across the areas and so on, which is valuable to the use of IPMS. We have as well audit functionality, where we can audit users within sites again around the appropriate access within IPMS records that they're viewing for their area. So that's just a short, brief overview of IPMS itself. Now, as I mentioned, IPMS is the core platform, and within that, it feeds out to our various systems. But also within IPMS, we are capturing the individual healthcare identifier number, which is the IHI number, and that in itself will feed into the National Share Code record, which Anne, my colleague, will talk about in a while. So with IPMS, what we have, which is a very good rating for our area, we have a 98.37% match rate within the records that are currently on IPMS and a match to an IHI number in the background. So again, this will help when we're streamlining the National Share Code record for our areas going forward. So my next slide here then is the patient record inquiry, and this is the one I mentioned previously. So I just wanted to emphasize this is our test patient test jack. As you'll see up here on the right hand side is our patient's demographics, PID number, date of birth. Here on the left hand side of the screen is an overall summary of the patient activity for the entire West Northwest region. So with that includes all of the acute sites and some of the community services. Now you can go down into each one of these tabs here separately and get further details around the clinic types they've attended, inpatient history, ED attendance, again, very important piece for your services as well, and so on. So here on the right hand side, what I have done is I have actually grouped it in date order just to give you an overall view of it. And we can see this patient, again, test patient, had an inpatient activity under Professor Trevor Markham for GUH. Now you can see down along here on the right hand side, we have the multiple facilities, and a facility is a site. So in other words, GUH facility, as in Galway University Hospital, Letterkenny University Hospital, Sligo, mental health services. Now, as mentioned, we do have mental health services set up. So there's 1 to 4, 5 to 6 Mayo services. You can see Sligo and so on. And then we have the Community Healthcare West, which sits here at the bottom. Now I could group those by facility if you're trying to look at the patient's activity across a certain site under a specialty and so on. So again, it's that integrated care of joining up the patient record, which is very useful if you are trying to see, let's say for your cardiology services, if you need to book an echo. Has the patient recently had one done in the acute site? If so, you can go in here, look at our outpatient activity and see that they attended an echo clinic recently, and then request the images, or you would have access to them on Evolve depending on the site. So my next slide here is the Evolve system, and again, our core platform is IPIMS, which all of the patient's demographics pulls across into the Evolve record. Now, I will say again, with that unique PID number for the patient and the fact we're multi-campus, if a patient is marked as RIP on the system and has passed away, a server runs overnight, which will cancel down all the patient's upcoming appointments and wait lists. So again, reducing down our wait lists and help streamline the approach within our services. So here, Evolve itself is an electronic clinical document repository system. So it's fully up and running within Galway University Hospital, Letterkenny University Hospital, with future deployments are currently being developed between the remaining acute sites and some of the community areas as well. So as I mentioned, IPIMS is integrated with Evolve using that singular PID number for the patient to pull in their demographics and so on. So Evolve is used to record, update and look at health information around the patient's individual journey. And again, it's an electronic record. So what that means then is that the community services can look at the patient's activity for GUH and LUH, let's say recent admissions, prescribed medication, clinical notes and so on, ED notes as well. And likewise, the acute sites can see what's happening within our community service around the patient care. We also have the ability to perform periodic audit functions. And again, this is around the correct use of the information that's up there in Evolve and the need to look at that patient's record. So within community services, we have access to scan documentation up into Evolve. We have the ability with the Evolve team to develop e-forms, which are used to capture clinical information. We also have access to a outpatient e-prescribing e-form on Evolve. And once completed, that prescription will go directly to the pharmacy that's picked and the GP as well. So within that, on the left-hand side here, you will see there's the individual folders around the documents, and within that we have document types. So all of the information is captured there then in one area for both acute and community. So my next slide then is around TPRO, which is the mobile dictation system that we have in place for the West Northwest. And again, this is used in all of the acute sites and some of the community services, in particular the ones for CHO2. So again, the core platform is IPMS, which in turn feeds down information into the TPRO system. So as I mentioned, TPRO is a mobile dictation system, so you can download the app on your work phone. Your clinic list will come up with your patient's name and so on the list. You can click on that person and start to dictate directly at the clinic using your work phone, or you can go in the afternoon, look at your clinic list and dictate a letter using your headset. So with that, there's the various work streams with regards to authorization groups. So you can have a single sign-off on an individual letter, or you can have a second sign-off, which could include a review of the letter by the consultant, and that sign-off piece is there. So once the letter is finalised and completed, a copy of it automatically sends to the GPs via a HealthLink feed. So there's no need to actually print any of the GP letters and post them. So it's automatically gone. And when finalised, a copy of the letter is also stored in the patient's Evolve chart as well. So with IPIMS and TPRO, the body of the TPRO letter here, say we'll pull in the hub details or the site details, the service, the clinic details, and so on. And then this information here is actually pulled from IPMS. So this is your referral source, as in your doctor's name, your doctor's practice, and again, very important piece. So it's the GP practice code, the patient's demographics, date of birth, PID. So the body of the letter is created already when you open it up. So what has to be inputted then is this part here. So we will do the Dear Doctor, comma, new paragraph. And as I said, as you're speaking, this is actually shown on the screen. You dictate your letter, you move down along it, format is done. And once finalized, then, as I said, a copy is gone to the Evolve chart and to the GPs as well. So my last slide here is the community care record. And again, with the community care record, this is part of the digital roadmap. We are the last site to go on to the community care record, again, because we have the ICT systems in place. And we will have, as I said, lessons learned from the other sites when the time comes to it then for our area. So that is my presentation. I'm now going to hand you over to my colleague Anne Keary, who is the ADON for the Regional Digital Implementation and Adoption Lead for the community, or for the National Shared Care Record.
Thanks, Dawn, very much. So as Dawn said, I am the ADON in the region, not just for the National Shared Care Record, but for a number of Digital for Care projects and other regional projects that will take priority to support implementations and adoption. So moving on to the next slide there, please. So I suppose today I'm going to give you an overview, a very brief overview of what the National Shared Care Record is. And I suppose ultimately, you know, how you as a health and social care profession may be able to get enablement and get access to the National Shared Care Record. So firstly, what is it? It's a read-only digital record, and essentially what it's doing is bringing a lot of aggregated information from various different ICT applications, whether that is from GP practice management systems, through HealthLink, through our community hospital ICT systems and community services as well. It is a web-based system, so it's really, really easy to use and really easy to navigate. And I suppose its main purpose is for you as a healthcare professional that you would use that as a supportive tool alongside with your clinical judgment. And I think what's really important, you know, we're bombarded with lots of different new digital for care, I suppose, programs. What's really important here is to know that it is not the electronic health record. It's a read-only platform. You won't be able to upload any information into it or change it or edit it in any way, but it's there as a supportive tool. So who can get access to it, I suppose? It is now live. We're very much at the early stages of implementation across our region. It's live and it's available to HC staff who have HealthIRL, who are on the HealthIRL domain, and who have an actual need to have access to that patient information. So that will be very much driven by line management approval through the National Service Desk in order for a person to get access. Of course, it's in line with HC policy and data protection requirements as well, which is really, really important. You know, as Vincent mentioned earlier about our cyber security, it's really important that we have a very safe and secure application for healthcare workers to get that integrated view of the patient. So moving on to the next slide there, please, Dawn. So why would you as a health and social care professional want to get access? As I say, it's going to give you various pertinent patient information from various different sources and settings across the healthcare ecosystem. It will ultimately aim to improve patient safety by providing visibility of various bits of information like medications, GP ordered laboratory and radiology results, discharge summaries from the hospitals, and even list out the various different recent hospital procedures a patient may have done, and so on. This QR code will lead you to further information around the National Shared Care Record, but don't worry, we have it at the very last slide as well, so if you miss it here, you'll be able to capture it at the end, and we will also share the presentation. So moving on to the next slide, please, Dawn. So I suppose I wanted to give you just an overview of the National Shared Care Record project lifecycle. I suppose it initially has started from 2022. We're now into 2026, where in November 2025, they would have tested the first, what they call beta users. So the pilot project were onboarded in November in the IHA Waterford and Wexford. And from that and their learnings from that, they were now able to stand up a number of regional services to support each region to implement and adopt the National Shared Care Record into your operational and clinical workflows. So I suppose that's where our team come into play. So there's myself, and there'll be a number of CNM2s, and there will be health and social care professionals later on this year joining our team to support that implementation. So certainly it will be really important, you know, for you as well, that if that's a role that you wish to get involved in, there will be opportunity for people to join our team on that. So just wanted to get that in there for any of you who have a very key digital interest. It'd be know that there will be an advertisement soon to join our team. So part of the onboarding process, we'll work through that towards the end of this presentation. But I suppose what's really important about this project, it's I suppose it's an agile project. So they have scheduled releases throughout each year so that they will add more data sets, giving you more rich patient information, so that at the point of care, you know, it's bringing that integrated view of the patient as that additional information comes into play. And I suppose the next slide then, Dawn, we will look at what's currently available. So if you were to get access today, this is the type of data sets that you will be able to get access to. And I suppose, you know, if I just pick out some of those, just even from a GP perspective, very often when we have a patient at the point of care, we're missing that very valuable GP information. So where a GP has recently ordered radiology or laboratory tests, really, really important information for the HC, I suppose, healthcare staff having access to, you know, will really enhance their ability to do a more comprehensive assessment or review of that patient. The GPs also have a key role in managing a number of chronic disease patients, and that information is now readily available as well. Even from a non-clinical perspective, you know, there may be opportunity also to consider non-clinicians to have access. If you look at it here, you have, you know, the visibility of recent appointments and upcoming appointments. You have visibility of what wait list the patient is in. So your administration team might benefit from having access to that additional information, so that they can, I suppose, schedule, you know, suitable appointments around that integrated care service that patient is already have plans to attend. So if we move to the next slide, and I suppose this is just to kind of give you an insight, you know, of the additional information that will be available just around the corner. We say in August, there's additional information, and again in November. And if I was to pick one or two of those data sets where I think it's going to be really, really beneficial, if you take the GP medications coming available in November, at the moment, the current National Shared Care Record only gives you a list of what are the reimbursed medications. So that's only giving a small picture of a person's medication status. But come November, once we get a feed from the GP practice management systems, it's going to be really, really helpful for us. You know, instead of having to repeat questions, you know, some of our clientele are quite elderly, mightn't have a good insight into their drug management, and are poor sometimes to give us that list. And a quick check on the National Share Care record will give you a good indication what was their most recent prescribed medication to help you have those conversations at the point of care. Again, you know, TPRO, I think, is another one that I would pick out here. Come November, TPRO clinical measures that Dawn spoke about earlier are going to be readily available on the National Share Care record. And I think, you know, particularly for the community audience who may not at this current time have access to IPEMS or TPRO, you know, that having access to this information in one platform will be really helpful, again, with you having those conversations with your patient at the point of care. We move on to the next slide there. So because this is a short, I suppose, webinar today, this is just giving you, I suppose, a snapshot of what it looks like. We just don't have time today to give a kind of a 10-15 minute demonstration of the system. But as you can see here, it's a web-based system. There are different tiles that you can, tiles that display the different data sets. So you can see at the very top there, you have radiology, the reimbursed medications, and the list of hospital procedures. You can go into each of those to get more granular detail. And again, you know, that pertinent information can lead to a lot of very, I suppose, concentrated conversations with your patient at the point of care. And it's giving that clinician an overview of that integrated care service that patient is having at this moment in time, either just recently, currently, or in the near future. So that information will be quite visible within the National Share Care record. So if you move on to the next slide there, please. So I suppose I felt it was important to just kind of give some of the existing feedback. So for health and social care professionals who are already using the National Share Care record, if you take the one on my left, the OT services, you know, we're able to look at the appointments that were upcoming for the patient from an oncology perspective, and that was able to enable them to decide when was the best time to bring that patient in for the OT community services assessment. And again, on the left, the physiotherapist, you know, in this particular example, you know, was, I suppose, trying to highlight that if the National Share Care record gives really quick access to the patient's care journey. And I suppose, you know, having access to diagnosis, radiology reports, discharge summaries, whatever that information, you know, will be important for that physio as part of that conversation. It just saves a lot of time searching various different ICT systems to gather a collective picture of that patient. So if we move on to the next slide there, please. So I suppose, you know, what's happening now? I suppose we're very much a team that are just coming together. We are given, I suppose, the permissions at this stage to support people to start getting enabled. But what we're doing first, we're doing an early adopter service pilot. We're working with the podiatry services here in the West as a starting point, just to get our learnings around the onboarding process. We're going to assess in a few weeks' time then a service impact evaluation, just to kind of further inform what benefits or challenges those users may have experienced. So David Watterson has kindly facilitated that as an early adopter service. We've been obviously actively engaging with Elaine Dobell as well, your regional director of the HSCPs, which led to this webinar to kind of give you that oversight of the National Share Care record. We will continue to engage with Elaine and her colleagues so that we can explore the best approach for onboarding as many of the health and social care professionals as soon as possible. And I suppose really this early adopter service rollout is, the learnings from that is going to, I suppose, support us on figuring out what's the best way to deploy. So I suppose, the next slide there, Dawn. That's, I suppose, an overview. I hope it's kind of giving you some sort of insight and maybe hunger to get access to the National Shared Care Record. I really do feel that this is going to be transformational for many people, particularly in the community where they, many don't have those, access to those core ICT systems. So I think, it will be a good opportunity for people to get enabled with this. So if you have any questions, I think we've come to the end of the I suppose the main presentations. If you have any questions, I think we'll be moving on to the questions and answers after this. Thank you.
So I've been answering some of the questions as we've been going along, but just a few, I'm going to group them together. There's a few that are similar, so I'll just group them by theme, really, if that's all right. So one question was from concerning Our Lady's Hospital in Manorhamilton and access to IPIMS, and who is the local IPIMS lead for that service, because that's really where we need to direct their question to about granting access.
Yeah, so I think, Paddy, just to maybe take the specifics of Our Lady's Hospital Manorhamilton, it's under the governance in SUH. So working that through in SUH, because IPMS is widely used. So working that with the team there, Sligo do actually, like most of our hospitals, have a very lean team. So, but working those requests through that team there aren't practical matters. All of the practical matters are worked out. It's capacity matters, if there's a challenge, but working that through with the team in SUH is the way to go there.
And
probably, Paddy, just to generalise that, the hospital teams actually have their IPMS implementation folks, okay, and so where there's things specific to a facility, working that with the local IT teams, that's the best way to go. On the community side, we're working to do as much joined up work as we can across the non-acute activities. And what Dawn has outlined is really where we were able to begin a little bit earlier than in the Northwest, because we were able to staff up in most form of CHO2, but the same plan is being approached there. And again, working that with the digital team to support the former community areas. Yeah, so that's the way to work that up.
Okay, thank you. The next question then is in relation to HSCP-led clinics, and we had a lot of work similar to this for nursing and midwifery clinics, and they're so
I think, Paddy, there's some of our facilities are using IPMS quite well in that context.
Yeah.
And again, it's probably context specific. So again, the way to approach that will be directly with the team locally, and where we've got to establish new kind of standard ways of doing things at a region level, we'll try and bring that through the individual facilities to say, okay, look, here's a way that it's working quite well in this place. Can we do something very similar in other places that need that? I suppose we have to recognise that some of this is makes assumptions around what the enabling environment looks like. So lots of our clinics have got admin support. Very often our HSCP clinics don't have that. So there's some nuances in that can make it a little bit harder to do. And it really is a challenge to get something that's super slick, that doesn't have somebody on an operations side trying to make sure that this stuff is done well, and that is definitely a conundrum. But one of the things that Dawn touched on there, this kind of patient identity, where we can be really robust about how we manage patient identity, and we attach as much activity as possible to that, even if it comes at a kind of that extra effort. it really is a foundation of safety. So having that assurance around the patient identity and our kind of clinician identity and our GP identity, having that through the IPMS platform does make it possible to do some more joining up of the information. But it isn't always terribly slick. Okay, but just again, specifically, if there's a bit of work to be done in the facility, having that conversation with the local team, if it's already established somewhere else and it's working reasonably well, seeing at how that might be used or that the pattern might be used or adjusted for the new setting that's being looked at.
Okay, and there's a question then on who. It's basically, will the patients have access to the National Sharecare record? And I'll hop in and I'll answer that one, that they won't. It's for the Health IRL HSE staff, that the patients will be able to access their information via the app. So that's how.
So Paddy, if I maybe just dip a little bit into the technical architecture a little bit, okay. So what's going on in terms of bringing those streams of data in? The program team that are running this at the centre, they're running this under one broader kind of platform label of what's called My Health at EU. Okay, and some of this is driven by, I guess, us trying to do a significant uplift in digital maturity. So what that platform team are looking to do is bring that data into the shared record and then expose it in the app. So that's the actual development trajectory that they've got. So the information that's presenting in the shared care record, their intent is to also present that in the HSE app and actually do it very quickly. So when they get it and they get the validations done and it's presenting in the shared care record, that it will also get reflected in the app. So that's the approach that the program team at the centre are taking. So you're right now, the shared care record, that will only be accessed by people in the HSE with Health IRL accounts. Okay, but the intent is that data, that very same data, will be presented in the HSE app to the individual service user. So that's the intent there, and I think there's already, as Anne alluded to, a lot of the integrations to get our IPMS appointments available in the app have been done. There's lots of really good information flowing there. I think the uptake of the app is growing reasonably quickly at the moment. So we'll see that happen more and more. And just specifically on this, the reason the Department of Health have pushed the creation of that app and exposing our data to patients in this way is they see that consumer demand is going to help drive our adoption and change. Okay, so that's really the philosophy that's coming and why the department have been so keen that the HSE puts this together. And we do our bit to make sure our clinics are ready and that information flows into the app. And some of that stuff is, it's equally important for, say, the HSCP-led services. And again, if we can actually just kind of plug those in on IPMS, all of that other stuff just flows if we do it right. So it's kind of that's a bit about the platform approach rather than the individual solution approach. Sorry, that's a very long answer, Paddy, but I hope that gave a bit of a just useful context. Yeah.
So the next question then in from Claire is, in relation to radiology reports, is it just a copy of the reports that the GP has received via HealthLink that are available? Because GPs don't automatically get a copy of all imaging, just the ones they've requested. That the report goes to the referrer is the traditional workflow. And is there a plan to integrate with NIMS?
There is a plan to integrate with NIMS at a later point. We haven't been given any kind of timeline around that, but definitely all GP ordered laboratory and radiology are that channel through HealthLink will be visible on the National Sharecare record currently.
If the GP is requested.
Clarification on that, sorry, Paddy, the clarification on that is as long as we've got an IHI coming from the GP order and going back with the result. And that's why it's so important for us to have the identity correct. And there's been a lot of work to strengthen that on the GP practice side as well. So to be fair, most of them and we can see on our side our current activity have that. So it, as long as that IHI is there, it'll get attached to the record and visible on the app.
Great. Next question then is about Evolve Access, and how do clinicians access Evolve, or have Evolve Access requests dealt with? Now, it depends on the service.
Yeah, so if
we don't have the licensing issue we used to have.
Yeah, so well, the licensing matter, we were able to resolve that. We bought an enterprise license because this was something of a barrier previously, but we now have an enterprise license, which we paid Kainos a lot of money for, but it does certainly get that problem out of the way. So read-only access is available in all of our acute facilities at the moment, and that's being organised directly by the implementation team on the ground in each of those hospitals. This will give access, obviously, to whatever record is there for the patient. All of the digitally generated documentation, such as that through TPRO, gets filed in Evolve. So if you're creating discharge letters or clinic notes against the patient's identity in IPMS, that will file straight away in their record in Evolve. The extra bit that Galway has is the physical chart is scanned as well. Okay, that's kind of a separate piece, but this clinical document repository for all of that activity is there. As the IPMS based clinics are included, that becomes available for digital dictation as well, and so that documentation files. If somebody's looking for read-only access, they can do that either through the community team if they're part of the community access, community services. If they're attached to one of the hospitals, they work within the hospital, they can do that through their local IT teams. They're doing the implementation and deployment locally. There's then bringing that additional digital data capture into all of our facilities, and so there's a piece of work starting to begin with some work in EDs on the acute side, and to bring it into the integrated care settings, the ECC settings on the community side. And we've done a pretty good job there. I think, to be fair, the value of that depends on what documentation is filed, much like the shared care record. Okay, and so where that documentation is all generated through kind of the IPMS links, that adds to that kind of really robust record and provides very good information for the digitally captured data.
Great. And this is a question from Maria. Are there plans to have the GPs on a single platform with the acute system? And I suppose this is the holy grail of a national EHR, but whether the non-HSE service providers will be truly integrated.
So at the moment, I'm not hearing anything along those lines. Okay, and I think one of the particular features of our health systems, our GPs are independent contractors. Okay, and we have, as a nation, we haven't gone down the road of requiring them to use a single information system. Okay, honestly, I think that's going to be quite some time away. I would suspect that's probably well after the National Electronic Health Record has been widely adopted. I expect that will be the time at which that comes. The bridging position is the shared care record, and so I think, as Anna's outlined there, what we're trying to do is try and get the the information that's currently flowing already to GPs, tap into that and file it in the shared care record. There is again, intent without a plan. Okay, and the plans are being developed. There's lots of things that they're trying to do. The intent is to have a summary record from the GP practice management systems that will be filed there. But that dynamic online use of the same record, Maria, I think that's quite some time away. That's my expectation. Yeah.
Okay. Now, the last question that's here at the moment. I was just about to type the answer first, but I'll throw it out. How do HSEPs get documentation filed on Evolve? Now, this is on the assumption, I'm reading that, on the assumption that it's a service who has right access rather than just read-only access.
Yeah, so just the digitally created will file automatically against that record as long as basically you're creating that against the identity as Dawn outlined there. When you do the digital dictation, you pull the appropriate identity into that, and that, like, we've done a lot of work to join the background, join that up. So that will file into the Evolve record straight away. I think, Dawn, there's a slightly different process in the integrated care clinics where there's some filing of the small bits of loose paper. Now, that's not scalable for everywhere, but do you want to maybe touch on that briefly?
Yeah, so what we have done for our community sites is we have enabled the ability to be able to scan documents up into Evolve as well. So like that, we have our folder types and our document types with a prefix of CHA in front of them, which is a community health area document type, let's say. So it's easy to identify that the information is coming from the community sites. So we've provided training around that. As I said, we were able to add additional documents to it and so on. So the process has to be agreed locally within that area of who scans and when. So like that, are the paper OPD referrals scanned in and by whom and at what stage, your clinical documentation and so on. So we have that implemented, as I said, for CHO2 already.
Okay, I'm sorry, Paddy. I just spotted the chat there. That was from Catherine. So that might well be within the GUH context that Catherine raised that question. So, but that's my guess at it. Okay, so that's something, Catherine, to work through with the team there in GUH. So just kind of working out what's currently a little bit sticky about that, if that's not currently happening, to just figure out what are the work plans what are the workflows to ensure that documentation does get scanned. Okay, so that's that again, if you're working within the acute facility, just working with your local team is the way to try and see how does this come together. Sorry, I'd only spotted the chat there. Excuse me.
And there's one more question then in the questions and answer section. Can TPRO be used if the person isn't also using IPIMS, i.e. can they be used separately, or does the person have to be using both together, which we get, most of the value from? But
so I think it is possible, but we're not supporting that at the moment. Okay, so it is possible to use TPRO independently, but actually we lose a lot of the value of joined up care if it's done and it's not actually contributing to that joined up record. So it's really about us trying to get towards these platforms, and that we are all working towards that joined up record that makes it safer for our service users and our patients, and it makes it safer for our staff to be able to use that. So that's why we've got to get that core enablement done, and then these additional value add layers just bring that much better coherence in our ability to do it. Now, it's not easy because some of the workflows change quite a bit when you try and move to digital from things that have been like there's nothing as infinitely flexible as our paper, okay, and I still rely on it myself, I have to say, in many situations, okay. So moving to structured workflows that we have to do when we really shift to that digital context, it's non-trivial, but actually what we're really looking to do here is improve the safety of the services and the effectiveness of those services and the efficiency of those services by having that joined up patient record and doing it in a way that we preserve the privacy, and that we, if we can all imagine ourselves or have family members who come to our services for care, and we've got expectations about how our records are kept private, okay, and that's part of getting this right, and that's part of, well, we don't just give access to anybody. That's done through a proper governed process around people understanding how we protect privacy collectively, how we audit that, but together getting to that place where people who are kind of helping patients that come to us with need, that you've got access to the information to really understand what that need is, come up with a treatment plan, and actually make sure they've got the right pathway in the right context to help them help them, get through the challenge they're facing.
That's great. Thank you very much. I'll hand you back to Nessa there now. And
thanks very much, Vincent. Very comprehensive answers to many questions, and I think the level of questions shows the level of interest in the topic, and we can see how these digital developments are going to really, improve care for patients and efficiencies for care for patients across all of our services. So finally, now we're going to hand you over to Elaine DeBell, and she's going to give us a short regional update, and she is going to close the webinar. So Elaine is the Regional HSCP Director, and she's been in post since February. So I'll hand you over now.
Thanks, Nessa. Grand. And I just want to reiterate thanks to Vincent, Dawn, and to Paddy. It's fantastic to have your experience and bringing the updates to us here. It's really good, and I think that the level of questioning and the number of people involved show that real interest and desire and want to be involved in this piece. So we may bring you back again in another year or so, just so we can see where we're up to in the future to keep it going, which would be fantastic. And I just want to reiterate as well, it came up during the presentations about these 2 digital HSCP posts. They are going to be so valuable and so important for working with the team, Vincent's team, and linking with ourselves to make sure we're moving with the times and getting the full availability of what's out there for us. So do watch for those. They'll be coming out again shortly. So please do watch them. We're looking for some people with real interest in helping to progress this agenda. So that would be great, please. The other thing just to say around digital as well, those people who are working in the community and are working on the therapy, primary care therapy waiting list, there's obviously a big piece of work we're going to be doing there around digital and IT enablement. So a lot of what we've talked about today is that, it's going to come to the fore going forward, which would be really helpful. And then the last thing I just want to say is to, again, thank you to you all for attending, and to remind you that this is an ongoing slot we have for webinars. So we have another one coming up towards the end of August, which is looking at practice education. Coru are going to come to that webinar, and they're going to give some information around student education and their criteria and so on. We're getting a few people to speak. If you'd like to come and present some good models of practice education, we'd love to hear people. We want some real good examples that people can engage with. So please do contact NASA if you've got some ideas around, what's worked well in practice education, whether that be how you manage the placements or what you've done with students on an individual basis, how they can be used to help promote and meet some of our priorities. We've also got a webinar on simulation coming up, and we will have one on the change guide coming up as well. So thank you very much for joining us, everybody. We will have the link available for the recording and slides and so on. Anne-Marie will send round afterwards. So thanks very much, everyone.
Take care.
Thank
Take care.
you.
Bye-bye. Bye-bye.
Bye.
Bye.